It's a reminder how much better we are together and how much more we can accomplish. So I thank all of you for coming together to make this center a success. The investigators, the community participants, administrators, and staff. And I know that it is a collaborative effort. And it also requires a team that is aligned. When you have an aligned team, you can accomplish so much more without the obstacles and the hiccups and all of the other things that come in place when you're misaligned. The center actually has demonstrated the value of interdisciplinary collaboration. Dr. Lowe mentioned some of it when he gave his introductory remarks, how this center really brought within UCR that meaning of what interdisciplinary research is and what interdisciplinary collaboration is and the benefit thereof. To my knowledge, we've not ever had that kind of collaboration across the multiple colleges and schools at UCR. And I know that this is just the beginning. You have uniquely developed approaches to integrate the environmental sciences, biomedical sciences, and the social sciences to address health disparities. And when we think about social determinants of health, it's clearly across all the sciences. And what better way to begin to address these disparities than to bring all of this knowledge base and expertise together. The center has become a model for the possibilities of collaborative research at UCR. When I think about the faculty development and what Dr. Moses has done, it's incredible to think that we started the Health Disparities Research Center, and through the center, we were able to bring our first hire, Dr. Mario Sims, who is impressive by far. And what his energy and his knowledge and expertise will do for our center, and bringing that into the mix of all that we have, it's just going to propel us to another level. While much has been accomplished over the past 4 years, I am certain that we will be successful in the renewal. And Dr. Lowe can tell you, I am a glass half full person. Maybe when it's half full, I think it's 3/4 full. And I really believe that we have what it takes to do it. But not only do we have what it takes, the work that we are doing is so meaningful, it's so significant, and so important to our region and to the people in the Inland Empire. And when I think about that work, I can't help but think about the faculty, the staff, and the students, and all of you in this room who are attracted to the work because you're invested in the health and well-being of underserved populations. And who wouldn't fund that? I think it's going to be a done deal. I'm going to sort of reduce my remarks because I really want to hear the next talk, and I know that you want to stay on schedule. But Dr. Lowe shared with me some of the specific aims for the center's renewal. And as I reviewed the specific aims to support an interdisciplinary and collaborative environment that merges a broad range of research approaches from basic biomedical sciences to social sciences and medical humanities to clinical outcomes research. And what I gleaned from it is that we're really moving it yet to another level longitudinally. The clinical outcomes research, we've certainly begun to do the basic things. We're bringing it from the bedside to the community, and now we're looking at the outcomes of the research that we do. And the research that we do is not doing research on the community, but having the community engage with us to determine what it is that they need and what we can do together to make a difference and to improve the health and welfare of the community. Creating that culture in community-partnered research methods that promote and expand genuine engagement of community-based organizations. And I underscore genuine engagement. And that genuine engagement calls for listening carefully, and listening with a desire to gain understanding. Because we often find that when we listen and listen well, we benefit so much more, and we get a better understanding of how we can come together as a team and make a difference. And I'm a believer that all ideas are important. I'm a believer in the collective wisdom of the group, and that when you have group decision making, you get a better outcome. And even when you think about group decision making, I'm not referring to moving towards groupthink, because I know that's also important that when and if you have a dissenting voice, that dissenting voice is also heard. Because sometimes through the dissenting voice, it can turn things around and you can get yet to a better outcome. So that openness is what I think makes the difference. And that sort of is the underpinning of what we do in community-based research. I also find that it's apropos that the Health Disparities Research Symposium is being held here at the California Air Resources Board, the Southern California headquarters. The work that we've done that focuses on health effects of air pollution, air quality, and the impact on the population, especially minoritized populations, really aligns with the mission of CARB. So this afternoon, the session will address the steps to health equity. And I really love that title, The Steps, because so often people think of the word health equity, or even the word equity, and think that we're going to wake up tomorrow and we're going to move from inequity to equity. There are steps, and sometimes they're painful steps that we have to take to get there. So I'm really looking forward to that. The advances and challenges of the COVID-19 era, inclusive mentorship, and the childhood asthma and the Salton Sea. I know you're going to enjoy the symposium, and I look forward to the continued impact of the Center for Health Disparities Research, and I look forward to hosting this symposium, not here next year, but within the School of Medicine Education Building. So thank you.
Dr. Medell Briggs-Malonson is the Chief of Health Equity, Diversity, and Inclusion for the UCLA Hospital and Clinic System. She's an Associate Professor of Emergency Medicine at the David Geffen School of Medicine at UCLA. In her current role, she's responsible for the implementation and oversight of organizational structures and initiatives that promote inclusivity and equity among UCLA Health staff, patients, and communities. Dr. Briggs-Malonson is also the founder and CEO of Contour Health Solutions, a national advisory firm that partners with health technology that improves the quality, safety, and accessibility of healthcare services for diverse and marginalized populations. Dr. Briggs prides herself in building a culture of innovation, collaboration, and excellence. This has led her to become a nationally recognized healthcare improvement advisor, speaker, and best-selling author. She's held several administrative and academic roles throughout her career, focused on innovative healthcare system redesign to advance health equity within diverse communities. Through her health disparities research, national lectures on implicit bias in medicine, and advocacy to recruit and retain more women and people of color in academic medicine, she's continued to increase awareness of how diversity within the healthcare workforce plays a critical role in eliminating health inequities.
Good morning, everyone. We're going to do a couple of different tech switches really quickly because I love to see everyone and engage everyone, and we are going to have a wonderful discussion, and it's going to definitely be participatory, okay? So just give us one moment while we switch, and then we will get started. There we go. Excellent. I think we are ready to go. So thank you so much, Dr. Tom, for that introduction. And thank you so much, especially Dean, to finally meet you, and also to Michelle and Catherine and the rest of the organizers of the symposium. And so as mentioned, my name is Medell Briggs-Malonson, and I'm the Chief for Health Equity, Diversity, and Inclusion at the UCLA Health System, and also an Associate Professor of Emergency Medicine there. But I'll tell you something else about me. I am now at home. So I actually grew up here in Riverside, literally. And so my father was actually an administrator at Riverside Community College, also a professor here at UCR. I grew up in La Sierra, Indian Hills, and my father lives down the street in Canyon Crest. So anytime, thank you. So this is truly home for me in more ways than one. And so anytime UCR asks for something, hands down, I'm here, because I remember being on the campus when I was both in junior high and high school. I went to John W. North right down the street. So this is truly home. And so it's just a pleasure to be here, and it's a pleasure to be back in my home city as well. And also just to see each of you all, and especially thinking about this important symposium of really taking a look at health disparities research. And so I am, and I'm going to get a little bit into my background, but I wanted to make sure that everyone just knew some of my roots. But one of the things I always like to start off with, especially for the students in the room, for the other young people that are actually aspiring to do this type of work, is that it's never a straight path at all. And my path has been all over the place, and you'll see why this is so important to this work of actually promoting equity and justice. And so this is a picture of me at age 5, literally, here in Riverside. And this is also around the same age that I decided, like, gosh, maybe I'll become a doctor. Not because I ever thought about it, but because I had an aunt who also lived right down the street, who was a nurse. And she saw me one day playing with her stethoscope. And she came over to me and she said, "Sweetheart, do you want to be a doctor?" And, you know, she didn't say, "Do you want to be a nurse?" She said, do you want to be a doctor? And she said that because she recognized the significant lack of not only people of color and Black people in particular in medicine, but also women. And which even still to this day, we only make up approximately 1.5 to 2% of all the physicians within this country. But it's the same for those in public health. It's the same for those in research, whether it's basic sciences or clinical. It's the same in social sciences. That's why we need people of all backgrounds, all identities, because it does make a difference on the voice that we bring to the table and how we drive change. So after I decided at age 5 that I was going to become a doctor, I actually did go to UCLA at that time. So I left Riverside in Sacramento where I was, went out to Los Angeles. And during this time, even when I was here in Riverside, I started to notice as a young person, things aren't right. Because I had friends, even right down the street off of Ohio Avenue and everything else. And I also had friends also down in the La Sierra area. And I remember some of my friends when we were in junior high and high school, when they were like, I'm not feeling well. And I'm like, well, go see a doctor. They're like, I don't have a doctor. I have to go to the clinic and I have to wait long time period. And for me, I was like, I don't understand that because, you know, my parents, they were professors, administrators, teachers, so we had access to healthcare. But my friends, my best friends here in Riverside did not. And then when I went to UCLA and I started to go to all the various different areas in Boyle Heights, in South Los Angeles, in Leimert Park area, in Crenshaw, some of the same trends, where there was lack of access to care, where there wasn't high quality care. And then I noticed that especially the communities that were lower income, Black and brown communities, tended to have all the worst outcomes. So I was like, what is this? What is going on? Because there's a difference in the way that people are living and succeeding in life. So I knew there had to be more that we had to look to. So that's when I actually was applied and was accepted to Harvard Medical School and Harvard School of Public Health. Now, let me go back to this, and especially for the young people in the room and online. There's something that's within our country, and which solely because of the way you look, potentially because of your neighborhood, your family, you know, your language, your citizenship status, whatever, that people will try to limit you. I cannot tell you how many times people told me, you will not become a doctor. People like you do not become doctors. People like you do not become researchers. I can't count the number of times I heard that in Riverside, Sacramento, and even at UCLA, where I was in classes, where I received an A+ in a class, and that professor told me straight to my face, he's like, good luck getting into medical school. Although all my grades were good because I worked so hard. So needless to say, when I did get accepted into all the medical schools that I applied to and then matriculated to Harvard, I sent that professor a nice little message saying, thank you so much for all your support. I'll be going to Harvard in the fall. And had to drop that mic. And I bring up this story to say no one can put limits on what you can do and what you can accomplish. You get to make that decision. Even if they are your professors, if they're your family members, friends, no one gets to decide what you are and how you can impact this world. So following my training, I actually selected to go into emergency medicine as my specialty. And I left Boston after 5 cold years getting my MD and PhD and came immediately back to California. And I decided to go into emergency medicine because for me it was important that I could provide high quality, equitable care, although people didn't talk about that, but we'll talk about that in a moment, to anybody that walked in my doors. Meaning, regardless of your race, ethnicity, gender identity, sexual orientation, ability to pay, citizenship status, language, I didn't care. If you needed care, I wanted to be able to get that for you. So that's why I went into emergency medicine. And I also did it because I feel that the ERs are the windows to the soul of the community. We see everything, both good and bad, that's going on in the community. So I came up to Harbor UCLA, which is a publicly funded hospital in Los Angeles, and I trained there. And immediately afterwards, I knew, gosh, I got to do more. Like, that's just not enough. Like, while I love taking care of patients one by one, there's more there. I care about communities. I want to drive and improve health outcomes for communities, especially our most under-resourced, ignored communities in this country. So I was selected to be a Robert Wood Johnson Clinical Scholar. And a Robert Wood Johnson Clinical Scholar is now called the National Clinician Scholar Program. So I'm dropping little pearls for everybody, okay, for additional research opportunities. But they taught physicians and now nurses and now also other healthcare professionals about not only how to be a leader, but how to conduct health services research with an emphasis on community-based participatory research. So that's how I got involved with community partnerships, as well as understanding how the community knows what's best. Not us in academic centers, not us in healthcare centers. The community knows best. And therefore, we can't improve health outcomes without centering the voice of the people, period. Nothing else, nothing more than that. And so that's what was so important there. And then the last thing is that then I was like, okay, I did my fellowship. I learned all about health services researcher. I'm going to go into research. But is that all that I really want to do? So there was something still in me. And around this time was about 2000-ish or so, the early 2000s, and several reports came out from the Institute of Medicine, and especially talking about quality. So no one talked about equity back then. It was just all quality, right? And it was health disparities, not health inequities. So I was like, you know what? This may be a path for me to think about the quality of care, because if I can impact the care that's provided to all populations, then that's how we can move the needle. So I joined the faculty at UCLA right after my fellowship. I was actually one of the first quality officers and then also an assistant professor of emergency medicine. But around that time, there was something new that was going on in Los Angeles. There was an old hospital by the name of King Drew that was established immediately after the Watts riots. And it was established to make sure to provide high quality care to the areas of South Los Angeles, Watts, Compton. But they had closed their doors because of poor quality. And that very large, lower income community of color, predominantly Latino and Black, had no healthcare services, with a population of 1.5 million people. So it was decided and signed into legislation by no other than Governor Schwarzenegger at that time that we're going to build a new hospital. But this time it's not going to be a publicly funded hospital. It's going to be a private hospital. And it's going to be a private hospital that is ran by a not-for-profit organization in partnership with UCLA. Well, UCLA, at that time, they were like, oh my goodness, we're going to have to do something with that hospital that has this long legacy of not being a good hospital. And yes, they're trying to create it. How does that work? And they're like, well, gosh, we need somebody in quality, because the legislation said UCLA had to provide the quality oversight as well as the physicians. Well, guess who had just joined the faculty, right? And so the CEO at that time came to me and said, crazy idea, Medell, crazy idea. We know you're like extra junior faculty, but we know your research in South LA. We also know that you're focused on quality and you're one of our emerging leaders. Would you be interested in partnering with this new organization to be the inaugural quality executive to build a brand new hospital in South Los Angeles from the ground up? Brand new. Greenfield. You'll go in, you'll oversee quality, help with the doctors. What did I say? Absolutely. So I said, absolutely. In order to build a brand new hospital from the ground up, built on best practices of quality for a community that I love and that deserves nothing but the best, count me in. But every single mentor I had said, that is your career suicide. Do not do that. Do not go. You're brand new on faculty. You don't know enough. You haven't been able to be exposed to healthcare systems. They said, don't do it. Don't do it. You're going to end your career right then and there. And in addition, all the rest of the more senior faculty, they're like, we're not touching that with a 10-foot pole. But I definitely did. And we, along with many others like Dr. Elaine Batchelor, and Dr. Elaine Batchelor is now a UC Regent, in fact, and many others built this hospital from the ground up to the point right now it has a leapfrog grade of an A. It also has almost 5-star CMS quality stars because of how we built it. And so that just shows that when people care about community and care about access to various different services, what a team can do. Now after this, though, I had children, and I decided to step away from hospital administration for a little while, and I developed 2 different companies. And I developed 2 different companies. Number one, my own speaking company, really focused on community education, health education, talking about implicit and implicit biases, but then also really focused on workforce diversity. But also, due to my time at MLK, when I was over quality, I also ended up becoming a techie. So I helped to design the entire technology systems there at MLK with a quality lens, and then not only with a quality lens, making sure that it was going to be able to interact with the people of the community in the appropriate way. So it was a niche that I developed, and I was like, while my children are young, let me start this company and be able to help other health technology companies, health systems, also meet the needs of our most under-resourced, vulnerable population. So that's what I did. But then around that same time, I was recruited back to UCLA in order to do some more work around clinical effectiveness. And then what happened? The pandemic hit. And with the pandemic came what else? A racial reckoning. That, oh my goodness, we now need to have chief diversity officers, health equity officers everywhere. And so I was already back at UCLA doing the work that I do. And then in addition to that, I was recruited back and say, are you interested in being our first chief diversity officer? I said, no, I'm not. They're like, why? Because most of the time, organizations recruit individuals to be chief diversity officers, and it's pure performance. It's checking a box, period. They're like, we're not about that at UCLA. Okay, well then add health equity onto it, because we are a business of providing care, and if you want me to be in this position, you have to be ready for change of this organization. The CEO said, absolutely, and she's lived up to her word. So that's how I became the chief of health equity, diversity, inclusion for the UCLA Health system, which is over 5 hospitals, almost 300 clinics, and we're expanding daily and really rooting equity and justice into the principle of our people, our patients, and our community. I won't go over all of our strategic plans, but you're going to see some of this. So why did I actually bring that up? I brought up all my background, yes, for those young people to think about all the different areas, but to also show why this work is so incredibly important, because all of us in this room care about all of our most under-resourced and vulnerable population. And so what is this quest to achieve health equity? Well, the quest to achieve health equity, I feel, is a couple of different things. But this is a pyramid from the Institute of Medicine report that was published in 2001 called Crossing the Quality Chasm. Who remembers this? Does anybody remember this? Yep, I know. And this is what sparked me to go into quality. And so what it said is that if you're going to deliver medical care in this country that is high quality, it has to be safe. It has to be effective. It has to be patient-centered. It also has to be efficient. And what's at the top? It has to be equitable. This is in 2001, 22 years ago. But guess what happened in the healthcare industry? And again, I'm going to speak from the perspective of health systems, public health. Guess what happened? Nobody ever talked about that 6th determinant. Everybody ignored that 6th one. I can promise you that. Everybody's like, equitable. We don't know what that is. You mean we have to talk about race? We have to talk about gender? We have to talk about we're not doing things right? Although 2 years later, the other report came out, Unequal Treatment, which is another landmark study from Institute of Medicine. But people are still like, yeah, let's just pretend we don't see that equitable piece of high quality care. And so what it actually ended up doing is that when we think about equality and equity, equality is the base, meaning those best practices, those standards, in order to just meet the bare minimums. But equity is when we're providing services, both health services, social services, to meet the individual needs of each person and community. And then inside of that, we get that you can't provide high quality care if it's not equitable. We defined that 20 plus years ago, but we're only just now catching up in this country. So what does this mean for us? Well, this is another diagram, and I always like to go through definitions because I always want all of us to be on the same page. And so this is a diagram from the Robert Wood Johnson Foundation, and this is their newest diagram. You all may have seen the people riding the different bicycles, and that actually demonstrated equality versus equity. Well, this is the newest one, which was designed to be even more inclusive. So let me show you a little bit here. I may not have a pointer. So here, the first panel, you have equality, where you have 4 individuals, clearly different, very different needs, and they're all trying to cross the street. There's only one little sign that says, hey, this is the crosswalk. You have a gentleman that's out in front who's a little bit taller, a little girl in the back who may not even see the cars. And then you have a gentleman that also seems to be visually impaired, and also a woman in a wheelchair who now has to go off of the ledge and can't even see if there's a car coming. This is equality. This is the assumption that everyone benefits from the same thing. But we know that's not right. The next image on the other side is that now people have looked at the environment and realized this is not conducive for everyone. And especially for everyone with their different identities, their different experiences, their different needs. So now what you see is that there's both audio and visual alerts to say when it's time to cross the street. You now have a ramp so that anyone who's using a wheelchair can go down safely. And now that little girl's out in front so she can also look left to right to make sure there's no cars coming. This is a demonstration of equity, where the environment is assessed and modified so that everyone can safely cross that road. So the definition of health equity, which most of us tend to use as health equity warriors, and I'm sure you all do too, is that health equity is achieved when there are fair and just opportunities for everyone to be as healthy as possible. That's what health equity is. But is health equity all that we need? I want to get into justice. And the reason why I wanted to get into justice is that I've been thinking a lot about this. And I've been thinking a lot about, yes, it's great that we have equity and we're addressing the needs of our individuals and communities, but are we getting to the root causes? Or are we just kind of like putting on Band-Aids and adding more resources, although they're targeted resources? Are we really making a true change? So these are the 4 definitions of justice. Number 1, distributive justice. Distributive justice is what we also tend to think of economic justice. So fair distribution of resources, whether it's money, healthcare services, clean environment, housing, all of those different factors. And then the next form of justice that's listed here is procedural justice. This is what we tend to think about when we think of law enforcement and the criminal justice system, and which is like, gosh, everyone deserves a fair treatment when they are accused of one thing or the other. That's procedural justice. But then you have retributive justice, which is essentially your eye for an eye, right? You do something bad, somebody's going to do something bad to you. That is the principle that the death penalty is actually based on. And then last but not least, we have restorative justice, which is actually increasing significantly within our academic centers, and which the idea of restorative justice, which is even reinforced by the AAMC now, is that when someone is harmed, that restorative justice, the goal of it is to improve that harm, to heal that harm, not only for the individual, but also for the community. in order to prevent that harm from occurring again. And you center the voice of that person who was directly impacted. We hold a lot of RJ sessions at UCLA, okay? And it's actually been pretty helpful and successful. So what does that mean for all the work that you all do as researchers in this center? I want to go into thinking deeper about justice. And I want to tell you all a beautiful analogy that Dr. Kamara Jones uses. And Dr. Kamara Jones, if you all don't know her, you need to Google her and look her up and read all her books. She's the former president of the Public Health Association of the United States. So sorry, I'm not getting the right term, but she is a powerhouse. And this is an analogy of hers. This is where we're all going to participate, okay? I want you to hear your voices. So let's say we're all at a pond and we see this fish belly up. What questions are you all going to ask? You're researchers. What questions would you have? So I hear, was the water polluted? Yeah. What else? Yep, so what businesses, what municipalities, and you may also say, like, did this fish eat something? Yeah, I'm sorry? What caused? Yeah, what caused this? Exactly. What caused this fish to die? Did they eat something? Did they have certain behaviors? Was something actually put inside of them? Yes, and I saw another hand over there. I was going to say, does anybody rely on that fish? Does anyone rely on that fish? Like, who is this fish? And what happened to this fish? Well, let's say you come back the next day, and then you see this. What are you going to say then? What was that? Something's definitely wrong. But something's wrong where, though? Something's wrong in this water, and it's a little scary. What else? Yep. How are we going to stop it? What are we going to do about it? Is that what you said? And who's polluting? Like, why are all these fish dead? And this is actually concerning. But then all of a sudden we say, okay, here's one pond. Then we hear there's a second pond. And then we hear there's a third pond, all separated across the Riverside area. Let's make it broader across the state. Let's make it broader across the country. What are you going to say here? How are all these fish dying in ponds that are literally separated from each other across the entire country? What's going on? Climate change? Okay, absolutely. What else? Where are the ponds located? Exactly. Where are they located? And then we look at that, and let's say they're just various different areas. Yes. That may be right around certain ponds in certain areas. Yes. Anything else? Any other questions that we as investigators would ask? All these dead fish. What source is the pond? And so we ask all those questions. And what we realize is that although, this is bringing up to environmental justice, folks, although we look at most of our water above ground, the vast majority of water is actually below ground. It's the groundwater. And no matter where ponds exist in our country, in a terrain, there's always a much deeper groundwater that feeds all ponds. And that means all the ponds are connected. So how can we translate that into what we see in our society? Well, we have a lot of dead fish that pop up. We have a lot of dead fish that pop up in health and healthcare. We have a lot of dead fish that pop up in education due to low quality education, lack of educational attainment. We have a lot of dead fish that pop up in economic opportunities, business ownership, home ownership. We have a lot of dead fish that pop up in the criminal justice system, where we have disproportionately higher levels of Black and brown men and women that are actually within our criminal justice system. And then we have environments where we know that there's certain environments, certain communities that have more toxins, more lead in the water, right? More pollution. I grew up in Riverside in the 80s. Our sky used to be brown, literally. We did not even we couldn't even go out to PE sometimes, truly, here. And then also social welfare, where certain children are placed in foster care systems more than others. And they tend to be children of minoritized backgrounds that tend to go to foster care more than others. Although when you look at the research and the data, there's no difference in how they're interacting with their families. So, what's the groundwater that connects all of these different ponds of inequities together? What is it? What is it? So poverty, that's go deeper. Racism. Structural racism, and other forms of significant discrimination, which tends to cause societal inequities in all these different areas. So we're going to talk about that. We're going to talk about how structural racism, which is, again, not interpersonal, not one-on-one, but racism that is built within our systems and our structures and our operations of our society and institutions, how this actually results to that. So, health equity and justice. Couple more definitions, because as I said, I love definitions. Health equity. Now you all are experts. Fair and just opportunity to attain their highest level of health possible. Health care equity is actually fair and just access to healthcare services and outcomes. And then there's also health justice, which we're going to go deeper in today. Eliminations of systems of oppressive powers that actually prevent individuals from all identities and backgrounds from in order to attaining their highest level of health. Systems, you all. And we're going to focus today on systems because you all are the brilliant minds, and we need all of your minds to really go deep into how do we identify, dismantle, rebuild the systems that drive overall health. So, equity is the path to justice, but equity is different from justice. And what I mean by that, and this is something that I've been thinking about a lot of, and several others in this space, is that equity is when we are in systems of power that cause inequities, but we're doing whatever we can to ensure everybody can gain their highest level of health, but we're still in a broken system. I'm going to say that again. Equity is when we remain in these broken systems of power, but we do whatever we can to ensure that the individuals and communities still are able to be as successful and healthy as possible. But what's the real solution? The real solution is what? Fixing the system. Why are we constrained within broken systems and trying to say, oh my goodness, we have to help here and help there, instead of identifying that broken system and saying, this is broken, this is not benefiting everyone, let's build a new system. And that's what justice is, you all. Justice is when we have complete elimination of systems of power that cause the inequities to begin with. But in order to do that, and even when we are impacting health, we have to take a look at the social factors, the structural factors, the political factors, the economic factors. And that's what takes us into the steps to achieve health justice. Equity is a step to justice. Equity is not our endpoint. Justice is. So, a couple of different steps we're going to go through. How to deploy an analytic framework, identifying root causes with a justice lens, targeted interventions for system reform, and last but not least, advocacy for accountability. So I am also I'm a performance improvement person, so I'm really into Lean Six Sigma. So that's really how I've always conducted my research and always conducted all of my health systems transformation and implementation work. And so I tend to use a framework by the name of DMAIC. It's actually a Six Sigma framework. And I use it because I think it's simple. And every time I've used it, actually been pretty successful. And the reason why you'll see, and many of you all, I am positive you do this in your research as well. And so what the DMAIC stands for is define, measure, analyze, improve, and control. And underneath each one of those things is number one, define, super simple, defines the problem. That's what we tend to do a lot of in of course, health services research, basic research, clinical research. What's the problem we're trying to fix? The second one is measuring. We tend to know how to measure, right? That's where we get the data. That's when we do the whole entire protocols and scopes, whether we're doing qualitative research, quantitative research. We tend to know how to measure the problem pretty well. But one of the things we may not do as much of, which we'll get to, is analyzing it. Really analyzing that data. And we're going to highlight some of these pieces of the 5 whys in a moment. But then improving is critical. Like once we understand the problem, we measure the problem, we analyze why that problem is happening, how do we build true successful interventions in order to improve that? And then last but not least, controlling it. So that once we make an improvement, we sustain that gain. That's the DMAIC product. DMAIC, super duper simple. So how do we apply this to our work? So I was reflecting again, and I was actually reflecting even for this presentation, but a couple of others. The McCone Commission, and the McCone Commission was a commission that was started in the Los Angeles area, again, exactly after the Watts riots. And this McCone Commission of all these different experts in so many different spaces of health and social work and education and criminal justice all came together and said, why did the Watts riots occur? Why did people get upset and burn down the city? And what can we do? And they set up all of these studies and found all of these health inequities. And this is back in the late 1960s, early 1970s. I think they published this in 1971. Identified so many different health inequities. And then I looked at some of those health inequities right now. How much have we improved? Throw some numbers out there. Less than 10%. I like that number. It's about that, y'all. We haven't really moved the needle much. Maybe 20% improvement, but in some areas we've actually gone backwards. So what are we missing as health disparities researchers and health inequity researchers? What are we missing in which the inequities that existed 50 years ago, I can take it back probably even longer, 100, 150 years ago, why do they still exist today? I think I may know how, I don't know, it's just a theory. But we're going to talk about that. And I think one of the challenges is analyzing. So, another chart. Significant health inequity in this country that really impacts we as the United States more than any other country. Has anybody seen this chart from the Commonwealth Fund? This was published in December 2022. And the Commonwealth Fund, and actually one of my friends and colleagues, he actually wrote this. And what they did is that they took and looked at all the maternal mortality rates of all high-income countries in the world. And what you can see from the Netherlands, and then you get all the way up to the U.S. And what you see here is that you first start off with U.S. Hispanic, U.S. white, all of the U.S., and then U.S. Black. That is the number of mothers that die every 100,000 births. 55 Black mothers die every 100,000 births in this country. 24 mothers in general die in the U.S. every 100,000. White, 19. Latino, also 18. By the way, I'm going to put this out there, especially for our Latinas. One of the things that we found in terms of maternal mortality is that oftentimes Latinas that immigrate to our country have lower rates of maternal mortality than Latinas that were born here in the U.S. I know, I saw you like, you're like, huh, that makes no sense. I'm going to say that again. Latinas that immigrate here to the U.S. have lower maternal mortality rates than Latinas that are born here in the U.S. Groundwater, you all. You got to think about that groundwater. So when we're looking at this, our overall rate, even for the United States, like all women in our country, we are exceptionally higher than all other higher income countries across the board. And then Black mothers, I mean, we are just off the charts, unacceptable. What about our babies? I'm sure you all talked about this one. I could tell you my email was blowing up. So this was just now published this week in the New York Times front page, talking about the title specifically, childbirth is deadlier for Black families even when they're rich. Oh, wow. Look at you, New York Times. And what this graph actually shows is infant deaths per 100,000 for mothers who are Black on the left, white on the right. And if you go at the bottom, you can see when you go to the right, the x-axis, the richer the family is. So what this shows is that babies born to the richest Black mothers, 437 babies die per 100,000 babies born to the richest Black mothers in this country. And this is from our state, by the way. This is from California data. And then if you look at white babies, 350 babies die to the poorest white mothers, and only compared to 173 babies die of the richest white mothers. So before there was all this talk like, oh, it's not race, it's socioeconomic status and all of these different things. Oh, no, this is proving otherwise. And I can tell you from my own birth experience as a Black woman physician, what happened to me and my baby. And that's a whole different topic. But I and my baby were very close to also not being here as well. And that's my own personal birthing story. So that's why I take this so incredibly seriously. So let's get to this. Let's go back and think about analyzing this. So we have a structure here where we have the symptoms, the problem, and the causes. Let's use the example of our babies dying here in this country. So we have here symptom. High-income Black infants die at a 2.5 higher rate of compared to high-income white babies and 1.2 higher rate than low-income white babies. We can say that that's a symptom. That's what we're seeing. The problem is Black babies die at higher rates even when adjusting for socioeconomic status in this country. Even when adjusting, and this includes money, this includes education, this includes access to healthcare, this includes everything. So what are our causes? Lots of things have been thrown out there all the time for literally the past 20 years of it's racism, it's chronic stress, isn't inadequate perinatal care, a whole bunch of those things. But what I want us to do is dig deeper and think about the groundwater and do everything with that justice lens. So if we bring up a new tool called the 5 Whys, and we're going to do this, y'all, together right now, because I want us to just go through that practice of thinking of this. If we bring up the 5 Whys, let's get to the root of the problem. So we're seeing that Black babies are dying at much, much higher rates than white babies or any other babies in this country. Somebody give me a why. Okay, education. Why education? So lack of education. Why is there a lack of education? And lack of education to whom? Okay. So the population may have lack of education because of lack of other people. Okay, so why would there be a lack of educational attainment? Access. So why is there lack of access? Okay, so I can even say, and I heard something over here too. Why is there lack of access? Okay, so historic and current racism. Why is there still historic and current racism? Okay, so it's systemic. It's built into our system. Why is it built into our system? This is your 5th why. Why is it built into our system? So it wasn't created by us. It's built into the system. Give me something a little deeper. So we have a caste system. What was that? Yes. What was that? There was something else? There was something else over here too. Protects the status quo. Benefits others. You see what we just did? And it wouldn't matter if we started with education and socioeconomic status or even just pure racism itself. We had to go deeper. To like, okay, yes, it's racism. Yes, it's lack of access. In this population, though, these women and these babies have high incomes, and we can assume high education status. So then what's the cause? So even if we say racism or protecting the status quo or other structural factors, but why? And we got down to the caste system and protecting the status quo. So the groundwater is built on that, you all. And the groundwater is still built on all of these different systems that promote inequities. And when there's inequities, somebody may be benefiting, whether it's intentional or not. But someone's benefiting and someone's not benefiting. So what do we do about this? Let's go back to the DMAIC framework. Let's go thinking about how do we change the status quo. So what we're going to do, seven social structural drivers of health. I'm looking for a clock. I'm trying not to be too much over. I'm going to ask Catherine to ping me if needed. But I like to call the social structural drivers of health versus determinants. And the reason why I like to call them drivers is because these factors are dynamic. They can change. They can cause someone's health to improve or they can cause one's health to decelerate. Versus determinant tends to be very static. And those of us that are in the field of healthcare, public health research, gosh, if we can't change a factor that's leading to somebody's health, what are we doing all this work for, right? So that's why I like to call them drivers. And I won't go too deeply into this because I know you all are all experts, but when we talk about the systems of power that cause inequities, the systems of power all exist within this. So when we think about economic stability and somebody's opportunities to have a high-income paying job, start their own business, own their own home, that's a direct contributor to health. But then we also talked about education. We know very clearly that high-quality education, especially in early childhood, actually accelerates an individual's likelihood of living a long and healthy, prosperous life because it allows them greater opportunities. In addition, neighborhood and physical environment, right? We know that that's directly connected to health. Whether you are experiencing homelessness or your home actually has various different toxins, that directly plays a role in your health. But then also, if you're living by the beach and you're able to go out in your built environment and go walking and like gallivanting, that also impacts your health in a positive way. But then we also get to food and food security. And this is something that I drill into my docs when they say like, oh yeah, I tell my patient to make sure to eat a healthy meal. Well, did you find out what's in their neighborhood? Did you find out if they have the grocery stores with all the fresh fruits and veggies and all the lean proteins? Did you ask them that? They're like, well, no. It's like, yes. Like, so you have to look at that individual and that community and make sure you're addressing the needs. So maybe a better option may be there's some new box subscriptions for a very low price that people can get shipped directly to their home if they don't have access in their community. And better yet, let's just advocate for higher quality grocery stores in our lower income communities, period. That's a whole entire another discussion and another presentation that I do to y'all. So I'm happy to come back and talk about that. But then we also have the community and social context, with racism and discrimination being at the top. And we know physiologically that when it is not race that causes poor health outcomes, it is racism that causes poor health outcomes. It has nothing to do with someone's biologic composition, but it's what they look like on the outside, where neighborhood they may be from, what language they may speak, all of those things that causes them to be subjected to discrimination, both not only within our healthcare systems, but also within society. And that causes a physiologic response within the body that is similar to fight and flight at all times. And then we wonder why women of color why people of color, why gender minorities, and others are having worse healthcare outcomes. Healthcare access and quality of care, of course, that's the primary domain. We're all kind of quasi in this domain, but we know we have a lot of work to do in this area. But I want to bring your attention to another one, technology. We are a digital first, not only nation, but world. And when people don't have access to technology, it negatively impacts them. And it's not just saying like the digital divide, do you have internet or not? It's more than that. It's saying, what type of internet do you have? Do you know how to log in? The devices, do you have the devices? Do you know how to log in the devices? Do you know how to use the apps? Do you have any of that at your fingertips? Because if you don't, it's much harder to navigate the world of healthcare and public health and also health education. So technology is what I call the seventh social structural driver of health that we have to pay attention to. So how do we take a look at all this? This is something called targeted universalism, and we're getting into the methodology now. And targeted universalism was actually first started at UC Berkeley, has now spread, first started in the education sphere. We are now fully embracing it at UCLA. And this is our new method. So I'm sharing it here with UCR as well. So targeted universalism is when you think about some type of problem and you set a clinical performance goal or public health goal, whatever you want, whatever your goal is. But then what you do after that is that you have to find the gap between actual and ideal. Well, once you define that gap, then what you have to do is take a look at the entire population's stratified and to see where everybody lives. And in this example, this false example, all people were below the goal, but then the A group, they're like over the goal, but then the B group is like much lower. So then you have to say, what are the special causes here? What's going on? What's the groundwater, right? And what are the systems of oppression that are causing B to be where it is and causing A to be where it is? And could that be due to social demographic factors, geography, environmental factors, all of those different things? But then you also have to reflect on the asset and the deficit model of saying, why is B so low? But also, what are the strengths of B that we could possibly harness? And then when we do that, we then can say, okay, the goal of universal targeted or targeted universalism is never to get B up to A. That's not the goal. The goal is to improve everyone's health. So think about going back to maternal mortality. Is it okay that just as a whole, here in the United States, all women are dying at much higher rates than women in other high-income countries? Is that okay? Are we okay with that? Absolutely not. Like, our mothers shouldn't be dying, but definitely our Black mothers shouldn't be dying at the rates that they are. So the idea is to set a universal goal for everyone to increase the health and the well-being of everyone. But then what you do is that then you develop targeted interventions for each group based off of their needs, their health needs, their social needs. That's what this is all about. And so how do we actually do that? So in your research, when we're saying, gosh, we have a problem, we see the symptom, we know the cause is part of the groundwater. Now we're going to develop new targeted interventions to identify that system of oppression, but then also making sure that we're trying to reform that system and eliminate it. That's how we get to this piece. Because those of us all sitting in this room, and I love that all of our community partners are here, that makes me incredibly happy because none of us can do this alone. We can't do this alone in medicine. We can't do this alone in public health. We can't do this alone in research. We can't do this alone only in community, although community has the strongest voice. But we have to partner with numerous people and agencies and stakeholders to transform these systems. And how we do that is, number one, the humanistic and moral case. When you find a problem, when you develop the solutions, when we're transforming the system, we have to present that humanistic and moral case. But despite how beautiful this mother is and how cute this little baby is, we've all been trying to use the humanistic and moral case for a long time of saying, this is the right thing to do. Everybody deserves high quality access to care. Everyone deserves to have the right outcome. Has that gotten this far? No. So I'm going to keep things very candid with you all. This is not enough. We all wish it was, but it's not. So when you're developing your research and your interventions and you're making sure it's sustainable, you also need to do the business case. And what the business case is, although sometimes it feels a little icky, I can see the faces here, if you can't show the value of your intervention and the value of no longer accepting the status quo and changing the system, if you can't show the monetary value of that, it will be dead before it starts. And that's just the truth. And this is one of the reasons why we still haven't achieved as much. And it's okay for us to think about this. And the reason why, and I want you all to think about it in terms of how we do the research, because we have to acknowledge what this country is even based on. The reason why race was even created in this country was to support chattel slavery. And what was the purpose of chattel slavery in this country? It was money. It was all money. It was to establish and grow economic wealth in this country. So that's why race was even created, to say, nope, we need slaves for free, because it's all about money. So in order to change the system, we have to acknowledge these systems and address these systems head on. And showing the value, which you can absolutely show. I've done this in numerous projects. Just received a $25 million grant from the state for an unprecedented project, which is specifically serving our most vulnerable populations, those experiencing homelessness, which are, of course, predominantly people of color and those with mental health illnesses. But we showed the value for sure. And therefore, it went on through. The last thing is that you have to prove the political case. Now, I'm not talking about like Republicans and Democrats and things like that, although that's another piece we'll talk about. But I'm talking about the pain points of people, the pleasure points of people, the negotiations of people. Everyone has something that makes them tick. All of our leaders, all of the people that support this work, everybody has something that makes them tick. And while we're developing our interventions and bucking the system and transforming the systems, we have to know everyone's care about, because we need to get them on our side for us to truly march towards achieving justice. So the humanistic moral case, the business case, and we got to do the political case, you all. And as researchers, we have to think about this if we want our research to really make the impact that we all want it to make. The last thing is advocate for accountability. I am a big accountability person. I feel that we all hope to change people's hearts and minds, but a lot of times you may not. But we can change their behaviors, okay? And so the number one thing is building strong relationships with all of our community-based organizations, our social service agencies, as well as all of us as academicians. Again, we have to be together. And we also have to look outside of health and public health and say, like, gosh, what's going on in the school system? What's going on in the social welfare system? What's going on in all these other industries that they're facing the same types of inequities? And let's bond together to build a stronger solution. That's how we also change items. But then in addition to that, we have to continue to advocate for the elimination of poverty as well as low education, and think about how do we really promote greater economic prosperity in our communities. And last but not least, we are here at UCR, and we are part of the UC system, which is a powerful system in this country. And part of that is also using our voices, using our influence to impact and influence local, state, as well as federal legislators to add accountability, to make sure that we are moving towards having more equitable and just outcomes for our patient populations. So in closing, number one, health equity is the path to health justice. It's a process, but our endpoint is definitely to achieve justice for all of our populations. Number two, groundwater systems of power that actually perpetuate inequities is where we need to focus our research and our attention. And then making sure that we're developing the interventions, the collaborative interventions, in order to achieve that. And then number three, of course, is a path to justice requires these primary areas: proven analytic frameworks, making sure that we have intentional identification of those groundwater systems, then have the targeted interventions to address that, and last but not least, advocate for accountability. So I always like to end on someone special in every single way. And Dr. Moses and I, when we first met, she said something, and I was like, ooh, I have something for her in my presentation. She said, we're always into good trouble here. And I was like, I'm right there with you. And this right here is Representative John Lewis. And I love this quote from him where it says, ours is not the struggle of one day, 1 week, or 1 year. Ours is not the struggle of one judicial appointment or presidential term. Ours is the struggle of a lifetime, or maybe even many lifetimes. And each one of us in every generation must do our part. We all must do our part, because every single thing that all of us do in order to drive justice is going to make an impact now, but definitely in the future. So thank you. It was an absolute pleasure.
So for this next session, we're going to have a discussion of COVID-19 impacts. Interesting. We're doing a study right now on the effects of the pandemic on family resilience and mental health, which we're not talking about today.
I think some relevant data. Maybe we can.
Oh, good.
Chat.
So that'll be great. Okay. So we have 3 presentations, and then we'll have some brief question and answer after each of the presentations, and then we can hopefully try and start to make our way back onto the schedule. So our first presentation is from Kalina Michalska, Ethno-Racial Disparities of COVID-Related Stress and Mental Health Problems. So.
Thank you so much. Thanks for being here. I'm Kalina. I'm an assistant professor in the Department of Psychology here at UCR, and I direct the Kids Interaction and Neurodevelopment Lab, the KIND Lab. So as you can imagine, the COVID-19 was challenging for a neurodevelopment lab. We use neuroimaging methods, and so we pivoted many of our research protocols to an online format, but I'm excited to share some of our findings today. And I will... I have the slides here. Okay. Tricky. Okay. I want to acknowledge my lab members first. I absolutely stand on their shoulders. None of this work would be possible without them. These are pictures of my graduate students and also undergraduate research assistants who do all of the heavy lifting. And so some of the work that we do in my lab is centered around how children understand the emotions of other people. And specifically, we're interested how kids learn about threat and safety, and then also how they understand the emotions of other people, so things like empathy. And of course, when you don't feel safe, the way that you interact with other people is compromised. So we do that in a population of Latina girls and their families who are at risk for anxiety disorder. They meet clinical diagnostic criteria for anxiety. We also are interested in disruptive behavior. Okay, I'm going to focus on anxiety. And essentially, we use neuroimaging and other methods to look at threat and safety learning. And so, you know, I think I don't need to tell all of you that worry is normative. I worry about giving a talk today, about making a good impression. Hopefully that's normative, right? So some degree of physiological arousal is normative. It's when these fear responses become persistent that they become problematic. So when they persist over time, that can lead to anxiety disorders, it can lead to distress, it can lead to avoidance of potentially favorable interactions, like in the classroom, like with educators, like with peers. And so the questions that we've been asking is, how are these fears learned? And then also we have a pretty poor understanding of mechanisms of how these are learned over development, which leads to a significant treatment gap. So we need a better understanding of threat and safety mechanisms in anxiety, and importantly, we also need to situate these experiences in the community, in the lived experiences of the community. So thanks to the Health Disparities Center, we have been really fortunate to receive some some pilot funding where we've been able to incorporate community feedback. We've been able to incorporate feedback on our methods, on our questionnaires, and our survey, and really try to engage the community in a collaborative process just to situate these fears. You know, what are the relevant experiences that lead kids to be afraid? And I have to say, the study started as a study on conduct disorder, and because of the fears that the community members endorsed, it switched direction to a study on fear, on anxiety, on worry, on separation, fears about immigration attitudes, fears about ethnic racial discrimination. And so that is really, I have the Health Disparities Center to thank for that. So I'm gonna, you know, it's gonna be a brief presentation today. One of the things that we have increasingly been focused on, thanks to HDR, are these sociocultural influences on threat and safety learning. Threat and safety doesn't occur in a vacuum. We don't learn about things that we're afraid of. We surround ourselves in the community, in a cultural context. And here, I like this model by Glass and McAtee, among others. They talk about discriminatory practices as regulators. So in the community, there are kids, adults, racialized minorities, minoritized groups encounter ethnic racial stressors that then act as regulators, so that then influence their sort of daily interactions. And so we've been trying to examine these sociocultural stressors, in part inspired by this model and others. I won't get into detail too much. In our designs, we have been doing our best to incorporate community-based participatory research methods. I presented a little bit about that in a panel yesterday. I'm happy to talk about this more. We have a paper coming out that outlines all of these methods. Many of you have been doing this work for much longer than I have. Many of you are experts from sociology, from gender studies, from ethnography. It has not been done in neuroimaging before, surprisingly. And so we've outlined a paper where we incorporate each of these methods, and I'm happy to get into that. I'm happy to share the paper. It's an approach that has not been used with the kind of methodologies that my lab has been doing, and I also have the HDR to thank for that. I think Sam and I were talking yesterday that you know, maybe we're in the kindergarten stage of incorporating these methods, or maybe just graduating to kindergarten relative to many of you here. So during COVID, obviously, we couldn't use neuroimaging methods, but we were able to partner with several labs across the country and internationally to look at what are the trends in mental health behaviors. I think many of us have the intuition that mental health deteriorated throughout the pandemic, and this is a paper that was just published a couple of months ago, showing that indeed, yes, when you look, and these are labs, we've all had pre-pandemic data. We had data ongoing from the pandemic, and we partnered with 12 different labs in the US and abroad as well. And what you see here is that depression symptoms are going up. This looks like small, but it's a significant effect across multiple labs. Depression symptoms are going up. Interestingly, anxiety symptoms have went down. The thing to note here is I don't think that anxiety went down. I think that the expression of anxiety went down. Kids are not in school. If they're worried about separation anxiety, they don't have the experiences that evoke these kinds of anxiety. So I think it's suppressed because it's not observed. But we do see influences on mental health behaviors throughout the pandemic across a large group of kids. It looks like biracial kids are particularly affected. They're particularly impacted by COVID-related stressors. The other thing that I wanted to also note is, yes, the pandemic absolutely impacted mental health. It absolutely impacted some kids disproportionately. Nonetheless, there were some, silver linings as well. So one of the things that we did when we transitioned from sort of more neuroimaging methods to online based research is we wanted to understand, what are parents doing? How are parents making meaning of the pandemic? What are they talking to their kids about during the pandemic? What is their narrative around the pandemic? And of course, there are structural and social barriers that impact this, but how are parents talking to their kids? And then does that impact what kids do, right? So I don't know if you all remember, I have a really vivid memory of the toilet paper hoarding, like with all the people having all the toilet paper. I mean, just wild. Probably they still haven't used all the toilet paper. So some people, in the face of distress, they hoard, right? I need all the resources. And then some others, they donate their time, they donate their resources, they donate their food. So what what leads to one behavior versus another? And so we looked at, we gave kids the opportunity to participate in our research study. And then we told them, you're going to get $20 for participating. And then we got a phone call and someone told them, we just learned that another child in the study is sick and cannot participate. Would you like to donate some or some of your money? You don't have to, it's not required. Would you like to? And so it turns out that kids are much more altruistic and much more empathic and giving than adults. And there was quite a large distribution. So many kids gave all their money. So my student Jordan Mullins looked at, first of all, are kids altruistically sharing their money and what predicts their willingness to share money. So we looked at trait measures and also other kinds of measures. So here she looked at child distress proneness and then parental post-traumatic growth and then the interaction of the two. So the upshot here is parents who found positive meaning throughout the pandemic. So in other words, not to say that it was a good thing, but parents who said things like, well, it brought me closer to family, it allowed me to spend more time with kids, to sort of express gratitude, had children who subsequently donated more of their resources, which is pretty amazing. And here we controlled for child age, we controlled for socioeconomic status, we controlled for how much money they had. So ongoing work, and I know I don't want to take up too much time. So that was mental health was affected by the pandemic. There were positive behaviors that also emerged, and those were associated with parenting. That means that parenting is influencing children's behavior. It also means that parenting influences child mental health problems. So here, what we are doing in ongoing work is we're looking at how parental socialization, so the way that parents talk about ethnicity, and these measures were developed by Cecilia Ayan here at Public Policy. Parents can speak about ethnicity in different kinds of ways. So they can either prepare children to, accept that they will be discriminated against, that, this is a racialized world, this is just how it is. They can also give kids the tools to stand up for themselves, to empower themselves. So there are different ways in which parents can speak to their kids, and we are looking at whether these socialization practices affect anxiety symptoms and also affects the neurocircuitry that is involved in threat and safety learning. And we've characterized the circuitry really well. I won't bore you with the neuroanatomy, but I've spent a decade characterizing this neurocircuitry. And interestingly, there is not work to date that has taken the experiences of minoritized kids into account when looking at threat neurocircuitry. So there's some work on trauma, on brain development, but not work that's really specifically looking at ethnic racial discrimination. So we're looking at these effects. We're looking at parenting experiences of discrimination, how they affect the brain. And then thanks to this work during COVID, we're saying that parenting acts as a proximal buffer to buffer against these experiences of discrimination. So some very early findings is that discrimination is indeed affecting anxiety symptoms. This is concurrent cross-sectional data, and some of these experiences are indeed mediated by neural circuitry. So the amygdala is a sort of hub for processing salient information, processing negative information, and what we find here in preliminary data is that discrimination experiences affects anxiety symptoms, and that is being mediated by the brain. Again, this is preliminary, so the next steps here are to show longitudinal association. So that is work that we're currently working on. We got a jump start from the Health Disparities Center. We're hoping to continue it and really to show evidence of causal links, and that will, I think, put us in a position to, reframe the narrative of how we're talking about mental illness, talk about sociocultural influences, maybe shift the blame from the individual to more of these social and structural influences that are impacting mental health through brain development. The cool thing about a longitudinal design is that we can look at change over time, and we can also look at transitions throughout the adolescent period where we see a lot of biological and social change. So with that, I'll say thank you. This is a picture of us on a recent conference trip where all of my students faced a variety of fears, including myself. I have a fear of heights, so we faced all kinds of fears in this trip. Thank you so much.
Hello, everyone. I'm Yijia Zhang. I'm a postdoc from the Center of Geospatial Science here at UCR, and today I'm here to present a collaborative work of myself and Dr. Ran Wei. She's also from the Center of Geospatial Science. And the talk topic is health disparity in spread of COVID in Southern California. And we are specifically focusing on three factors. The first is evidence from social distancing, and second is the risk of interpersonal interaction, and the last is access to testing. Some background of our study. So there are substantial literature that shows significant social inequalities in the spread of COVID-19. The theory of fundamental social course proposed that the reproduction of health inequality emerges when people use flexible resources such as knowledge, money, power, or prestige, and other beneficial social connections to gain advantageous health circumstances during different conditions of the COVID. However, to date, questions remain that how different factors that related to those flexible resources change over time and also varies across income groups during different stages of the pandemic. So we are specifically interested in three factors, which are first is social distancing, the second is the risk of interperson interaction, and the third is testing accessibility. And we want to know that if those three factors that might help explain the disparity in the spread of COVID across different income groups. And those are our three research questions. The first is, are there different COVID spread patterns across the high income and low income group here in Southern California? And the second question is, over time, what are the disparities in those three factors between the high and low income group? And finally, we want to know that among the three factors, how they are significant and how this significant change over time during the COVID spread. And here the map shows our study area, and you can show that the map shows the weekly new COVID case count per zip code on the data of April 13, 2020. And our study area basically covers about 600 zip codes here in Southern California. And the three factors we are using, the first is the weekly total population inflow, which is corresponding to the factor that captures social distancing. And the second is the interperson close contact index, which represents the risk of interaction. And the third one is the accessibility to COVID testing. And here I also show the, here I also show the year 2020 demographic data distribution of those of our study area based on the American Community Survey data. And the first map, on the first map, you can see that we actually using the median household income data, and then we divide all the zip codes into 3 different income groups. The yellow area, which is the first 25 quintile, so the yellow zip code shows the low-income group, and the dark blue area shows the high-income group, and in between are the medium-income group. And the second map shows the population density variation, and the last map shows the percent of Hispanic population variation in the study area. And the first our result shows the weekly COVID case trend from March 2020 to April 2021. And you can see here, there were basically 2 peaks which identified from the weekly trend. And the right bar shows the shelter-in-place and the business closed, the time of that, and the green bar shows the 2 reopen event during the state. You can see that before they first reopened, actually the weekly COVID increase was pretty low, and after the first reopening in May, we reached the first peak of the COVID during June and July in year 2020, and then there's a decrease of the COVID case during September and October, and then after the second reopen in October, there's a large growth on the COVID case increase, where you can see we receive about more than 300 COVID cases per zip code. And then the case drop again in the next year, January and February, and then become flat during April. So that's the overall temporal trend of the COVID case. And here is our 2 factors that captures the social distancing. Above shows the total population inflow that one zip code receives weekly. And the below map shows the count of interperson close contact per person received during a week. You can see that overall those 2 factors shows quite different temporal trends, and the total population inflow generally shows a consistently increased trend, despite of the different business close and other orders. However, the close contact rate shows a quite different trend. It has the highest peak during the July 2020, during the summer in 2020, and then has a smaller peak during the November 2020, and then after that it has remains at a lower level. And for the third factor we consider is the testing accessibility. We calculated using the enhanced two-step floating catchment area method. So for this method, in step 1, for each of the testing sites, which are the small dots you can see in the first map, we calculate the 30 minutes driving distance from each of the testing sites, and then create a catchment from that. So we get the number of lists of which are the zip codes that can reach this testing site with 30 minutes driving time, and then get a testing to population ratio in the first step. And in the second step, for each of the zip codes, we get a different calculation that counts that what is the sum of the testing to population ratio for each of the zip codes, and then get a summary of the weighted testing accessibility for each of the zip codes in the study area. And here's the result accessibility index. You can see that we have 2 maps which show the testing site distribution in March and May 2020, and then you can see that with the increase of the test site, there's a slight increase in the average testing accessibility from 1 to 1.1. And the shaded area actually marks the standard deviation of the testing accessibility difference among those 600 zip codes in the study area. And in the result, we first separate the COVID case trend by high income and low income. So the low income are shown in green, in orange color, and the high income are shown in blue color. And you can see there were strikingly difference between the weekly COVID new case between among the two income groups, and there's almost no overlap between their COVID case count. And the difference was smaller. The gap was smaller during the first wave, but then the gap became much more larger during the second wave. So in the second wave, you can see that the low income new case count were about 5 to 4 times of that of the high income. And here is the our factors. First is the population inflow, which characterizes the risk of the social distancing practices. You can see there, compared to the case flow, right now for the population inflow data, actually the high income and low income shares a lot of overlap. But then you can see that in during March, the total population inflow that received by the high income group were actually slightly lower than the low income group. And then after May, so after reopening in May, the high income group's total population flow actually increased and then become larger than the high income group. And the trend remains for the later course of the year. However, if you compare this trend with the map down below, which shows the interperson close contact rate, you can see that the high income and low income group gets no overlaps, and the low income group has a consistently higher degree of interperson contact compared to the low income has a consistently higher degree of interperson contact compared to the high income. And our testing accessibility result was quite interesting because you see that the low income group's average testing accessibility, which is colored in orange, was actually slightly higher than the high income. And we checked similar studies on the test, which also calculates testing accessibility. And one possible explanation for this is that low income residents mainly located in the urban centers. That's why on the data they may show better access to the testing sites. But most of the testing sites at the early stage they require a phone appointment or other restrictions. But we didn't capture in our data. This is like geographically, low income has a slightly better testing accessibility than the high income, which are mainly located in rural areas or suburbs. The method we use to calculate the significance of the three factors is a spatial lag model. And in order to consider the incubation, which is the 2 weeks incubation period of the COVID-19, we actually, so the Y variable we use is the previous weekly COVID trend. And the X variables we use, we actually move the variable to 2 weeks ago. So if we want to know that if there's something changed in those factors 2 weeks ago, what will be the result on the COVID case increase 2 weeks later? And the first factor is the 2 weeks ago weekly sum of the COVID case. So this is actually identical to the Y, but then its value 2 weeks ago. And then the second one is the population inflow, and the third one is the close contact events, and the fourth one is the testing accessibility. We've also adding a new variable, which is the CI neighbor. We want to use this variable to quantify that if there is, for example, if there's inflow of the COVID from the zip code, from another zip code to this local zip code, and also that zip code has high population inflow and also high new case count, if that also affects the local case increase. So that's how we identify and compute the CI neighbor. And here's our first result that shows the time varying effect of the local case and also the CI neighbor, which we define it as a weighted neighboring case. And you can see that the gray bar shows the significant variables of the local case over this 1 year from April 2020 to April 2021. And the orange bar shows the significant weighted neighboring case coefficients over this year. And you can see that those two variables exhibit quite different time varying trends. Generally, the local case has a stronger effect on the COVID case development compared to the weighted neighboring case. But if you see the first bar, which is in the April 6, 2020, you can see that the neighboring case becomes firstly significant, and then its effects drops over the time, and then and becomes smaller, and then the local case, the value of the local case becomes larger, starting in May and June in the year 2020. And then it dominates the local case growth in the first COVID peak, which is among June and July in the year 2020, and also during the second COVID case, which is among November and December of the year 2020. So we see the rise and fall and the alternative patterns of the two variables from this time varying chart. And on average, the local case, which is a gray bar, it shows the average coefficients of 0.5 because we logged all the variables. So average value of 0.5 actually means if you see a 10% increase in the local case 2 weeks ago, and you will see a 5% increase in the COVID case 2 weeks later. And for the orange bar, which is a neighboring case, the average value is around 0.3. That means 10% increase in this weighted neighboring case will result in a 3% increase in the COVID case 2 weeks later. And here we compare the two factors. The above is the population inflow, which shows the factor that captures social distancing practices, and down below is the interperson close contact index. And you can see that in terms of significance, the interperson contact is most significant compared to the population inflow, and also it has higher coefficient values compared to the population inflow, which means that the interperson contact was, based on our study, is most significant compared to the population inflow and contributes more to the local case growth. Okay. And here is the testing accessibility result, which is our last factor. And you can see that different from the previous positive effects on the COVID case growth, the testing accessibility is mostly negative, but then it's not very significant during, it's only significant maybe for about 12 weeks over a year. And that means if you see an increase in testing accessibility, then you will see a drop of the COVID case growth 2 weeks later. And that is mostly kind of aligned with our assumptions and hypothesis. So in sum, our key findings are, first, we do observe if we differentiate the COVID case growth by high income and low income, we do observe a slight difference between those two groups. And also, if we compare the social distancing factor with the close contact factor, we see that the high income group actually have relatively higher mobility factor, but then lower close contact factor compared to the low income group. And among the three factors we tested, the close contact index contributes the most to the spread of COVID, and the testing accessibility has the least impact. And for the two new variables we added, which is a 2 weeks ago local case and a 2 weeks ago weighted neighboring case, they both show strong significant effect on the COVID case growth. However, their strengths have different temporal trends. And our work still have some limitations. And the first is the testing accessibility calculation we did is based on county level testing data, and they didn't actually capture the zip code level testing variations. And the second is we didn't capture public transit in our calculation. We actually used the 30 minutes driving time. And the last, we are going to acquire vaccination data because our analysis is continued in the early 2021, where widely vaccination was becoming available. And thank you. That's all my talk today. And do you have any questions?
Thank you. So let's see. I think we can start getting closer to catching up before we'll have our next talk. Erica Heinrich. We'll go on to the next one, and then we can have discussions after. Erica, so population disparities in COVID-19 pathogenesis and long-term health outcomes. So here's the microphone, and it's still on, looks like. Sweetie.
Okay, so I'm Erica Heinrich. I'm an assistant professor here in the Division of Biomedical Sciences, and today I'm going to share just a little bit of this pretty massive project we've been working on, where we've been looking at population disparities in COVID-19 pathogenesis and long-term health outcomes. And I do want to thank, before I get started, many of the people who have helped with this work. So we've had several people in biomed who have been helping. So Mira Nair, Marcus Call, Adam Godzik, and everyone in their lab, including Chrissy, who's here, who's been doing all the hard work. As well, we have two clinical collaborators who have been essential, so Michael Ulrich and Patrick Merrill, who have helped with the clinical sample collection. And Herlinda, if she's still here, she's my hero, our clinical coordinator. So I don't think I need to tell this group, but COVID-19 hit Riverside County pretty hard. This is data that I pulled from the Riverside County Public Health website in November, actually. So we've had a few more cases since then. But you can see at that time there had been nearly 700,000 cases of COVID-19 in Riverside County, with almost 7,000 deaths. And this I know you can't see very well, but let's see if my pointer. So here, this is breaking up the case numbers and deaths by racial ethnic groups. And what I hope you can appreciate, on the left, that largest bar, there he is, that's the Latino population in Riverside County. So that's cumulative cases and then cumulative deaths in the Latino population. So you can see that they've bared the brunt of the pandemic in Riverside County compared to non-Hispanic white, which are all the way on the right. But you may be thinking, well, Riverside County is, I think, something like 54% Hispanic. But if you look at the case rates compared to the demographic distributions across the entire United States, you can see that the Hispanic Latino population was hugely disproportionately impacted. So that's that top bar there. The red is showing the percentage of COVID-19 cases in those groups, and the gray is the percentage of the population. So on that top bar, that's the Hispanic Latino population, and it's about 10% overrepresented in terms of the US population. And then we have the non-Hispanic white group here, which is actually underrepresented in terms of COVID-19 cases compared to their population distribution. But we also have differences across age groups in COVID-19 cases. So even if you control for age groups, you still see, I know the text is small, but this is the Hispanic group on the left, and they are severely overrepresented compared to their distribution of the US population in every single age group. And in fact, this median age group is, I think it's 25 to 34 years old. So that group is the most disproportionately impacted. And so what our group wanted to do was to look specifically at our area, and we wanted to identify disparities in COVID-19 clinical outcomes, so during infection, in the Hispanic Latino population. And then we also wanted to look at long-term outcomes. So for that first aim, the top in blue, that's work that we did in collaboration with RUHS. So we had Michael Ulrich who helped us with that. For those individuals, we recruited patients who were in the ICU with COVID-19 infection. And so these were patients that required either supplemental oxygen or invasive mechanical ventilation. We also recruited outpatients who had mild cases of COVID-19 and were candidates for monoclonal antibody treatment, but they were at home. So we actually went to their home to collect samples, which was a little bit nerve-wracking before the vaccines rolled out. And then more recently, we were able to start in April of 2022 our long-term study, so we were able to follow up with patients as well as to bring in new individuals. And we could look at the long-term impacts of COVID-19 on immune health and lung health. So we wanted to see first if there was a return to immune homeostasis following recovery, and then we wanted to see what's going on with the lungs after recovery from COVID-19. And while collecting all this data, we wanted to determine if we could identify disparities in long COVID-19 symptoms across groups. So this just shows, I need new glasses because I can't even see my own slides, but this just shows a list of the types of samples and measurements that we collected. I won't be able to show you all of this data today, but I'll show you a couple highlights. So for the ICU group, again, these were patients with severe cases, of course, and they conducted in-person consent. We got some information about their medical history, and then we collected nasal swabs for PCR sequencing so we could determine their viral burden, as well as we did viral sequencing so we could see what variants were going through the population. We also took blood samples so we could look at different immune parameters and biomarkers. And then in those patients, we were actually able to access their electronic health records so we could look at things like mortality rate, comorbidities, and the time they spent in the ICU. We took similar samples from the outpatients at their home, including the nasal swab and blood samples. And this was actually a really interesting part of this study. So what we were able to do is that while we're recruiting patients and collecting these samples, we sort of kept a dialogue going on with them, which is unique to how I've traditionally conducted my research. So we really wanted to keep them involved in the study. So what we did was we would go to their home, do the interview and collect the samples, and we would actually, as a benefit to them, sequence their sample, tell them if they're positive, and then tell them actually what variant they had, which people were very excited about. It was a huge draw, actually. But then I'd get to sort of follow up with them a couple times, so I'd get to see how they recovered, ask them questions about what they thought was important. And so this was a really, really a nice aspect of this part of the study. And then for the follow-up phase, we've been doing a lot of the same measures, some lung function and control of breathing tests as well. So this is just a summary of our current recruitment. So since we started, we've recruited 121 individuals. This includes 32 people with moderate to severe COVID, so these are in the ICU, 33 with mild COVID symptoms, the outpatients at home. And then for the recovery phase, we have 41 recovered individuals and 27 controls who are matched for age, sex, and BMI. These are people who have never tested positive, and to their knowledge, they've never had COVID. To their knowledge. So to the right, you can see that our groups are well matched for age across the moderate and severe groups. In our recovered and control, we do have a lower age range. So if anyone in this room has had or hasn't had COVID and is over the age of 30, we'd love to have you. And what we saw in the clinic was that individuals of Hispanic ethnicity were greatly overrepresented in the ICU. So 58% of the ICU patients were men, 32% women, and 88% of the ICU patients were Hispanic. So that's a huge overrepresentation compared to the proportion of Hispanic individuals in Riverside, which is about 52 or 54%. But in the mild group, it was only 27% ethnicity, and we have some ideas about why this might, or Hispanic ethnicity, we have some ideas about why this might be, which we can talk to you about afterwards. So in terms of the outcomes, of course, the Hispanic group was overrepresented in the ICU, so that could be interpreted to say that the cases were more severe in that group. However, on the bright side, there was no significant difference in mortality rate or the length of stay in the hospital across Hispanic and non-Hispanic groups. So you could interpret that as they're showing up at the ICU with more severe cases, but once they're there, they're receiving comparable treatment, at least at RUHS. So just a few more pieces of information about the clinical side. So 2 of the ICU patients had prior COVID-19 infection, and actually some people showed up at the ICU multiple times with multiple infections. Many of them had received the vaccine but still ended up in the ICU. I want to point out, so hypertension and diabetes were hugely common in people who ended up in the ICU, which fits with the national data. And diabetes in particular was predictive of survival. And so unfortunately, there was a high mortality rate in the patients that we recruited in this phase. And 78% of the patients who did not survive did have diabetes. The idea being that if you have these metabolic syndromes, diabetes, hypertension, obesity, that's going to lead to these downstream mechanisms where you might have impaired glucose tolerance, inflammation, impaired blood coagulation, or metabolic control, and that will all lead to poor COVID-19 prognosis. And when we looked at our data, diabetes was more common in the male Hispanic population than the other groups that we had. But again, I try and end the slides on a positive note. So of course, we've seen that things have improved. So at the beginning of our study, from January to June 2021, only 31% of patients we recruited survived. However, through that year, towards the end of the year, 78% of patients survived, and now we barely have any mortality in the ICU. So the treatments have really gotten better. I'm going to speed through a little bit of this. I just wanted to show, we have some really talented immunologists that we've been working with, one of which is sitting in the front row here, Mira. And so what we have seen that there's some differences in immune cell populations during acute infection. So here we have plots showing populations of different white blood cell types in healthy, moderate, and severe cases. And many of these cell types are being reduced in the severe COVID-19 cases. And interestingly, in the recovery phase, a lot of these don't recover back to their normal levels, even after like 200 days of recovery. So this is very interesting and unexpected. We also see during acute infection, especially in people with severe disease, that these markers of chemotaxis, which basically recruits immune cells to sites of infection or injury, those are elevated. There's elevated inflammation via this IL-6. There it is. And tissue damage, which we can see through elevations in myoglobin. And all of these factors are elevated to a greater degree in patients with diabetes, so we have a potential mechanism here for what's causing this more severe disease. So since about April, we've been able to start this follow-up study. So far in this group, we've been able to recruit, for the control group, 57% men and about 30% of them are of Hispanic ethnicity. In the recovered group, we have about 41% Hispanic ethnicity, some of which had more severe cases and were hospitalized, and many of these patients were fully vaccinated at the time they were infected. And our average time since infection is about 221 days. So some people are coming in, okay, thank you. Some people are coming in a long time after they recovered, but still showing symptoms. So I'm going to finish off by showing some of the long-term symptoms that people are reporting. So this is information from a questionnaire where people self-report their symptoms pre and post-COVID. And so in general, there is an increase in overall symptom severity as well as functional disability. Functional disability are things like having trouble communicating or getting to work, getting dressed in the morning, those sorts of things. And there's significant increases in many of these symptoms that you'll see on the right. I'm just going to highlight a few here, and then I'll show you how they differ across groups. This is kind of hard to read, but I'll point out here. So this is the severity of sort of cough, cognition problems. That's very common. Anxiety, a lot of our participants had high anxiety to begin with, but many people are having even higher anxiety after. We also have severity of fatigue, pain, and in many individuals, increased depression. And when we look at how the increase in these symptoms varies across different groups, we can see pretty strikingly, although we do need a larger sample size, in the Black population, the degree to which those symptoms have increased after COVID is much higher than in all the other groups. You can also see in the Hispanic group, there's many individuals who report high increases in these symptom severities compared to the non-Hispanic white group or the group reporting more than one race. We do need more participants in this study so that we can verify this. And I did dig into this data, and what's driving those huge increases is mostly cognition problems and depression. Those problems seem to be very high in the Black group here. Again, on the positive note, we have seen that lung function seems to return to normal in most groups. I'm running out of time, but this just shows, your lung function is mostly returning to normal, which is good. And then I'll leave you with a little, this is hot off the press, but we also measure the control of breathing. And there's a few people in here who have done this study, and so this is a very interesting test. But we measure your breathing reflexes, and we're starting to see that post-COVID, there actually is some blunting of the respiratory reflex, which may put people at a higher propensity for developing obstructive sleep apnea. So this is sort of an interesting result that we're looking into. And with that, I'll finish up. Just to conclude, I think the biggest take home here is that the Hispanic population in Riverside was greatly overrepresented in the ICU. Although once they ended up there, it seems that they received comparable care and had similar outcomes to other groups. And hypertension and diabetes are predictors of mortality, so as long as it's well controlled, take your metformin and things like this, the outcomes are much better. So I'll go ahead and end there and acknowledge everyone for their support of the work and all of our participants as well. Thank you.
It's Inclusive Mentoring for Success, and we have Yolanda, and we have, let's see, Davina Gonzalez, Mario Sims, and Dietrich Galloway.
This is a workshop format, and I have been responsible for the recruitment and retention core for the grant, and part of the process is doing research on not only how to recruit researchers, postdocs, and faculty, but also what kind of successes can we give them? What kind of environment can we create for the folks we bring to UCR to be successful? So our research turned up the fact that mentoring is scientifically proven to be one of the best ways to do this. Being HDR, we wanted to go one step further and not just talk about mentoring, but talk about mentoring based on the value system of our grant, which was to look at inclusive mentoring and mentoring for success for working with the populations that we want to work with. So part of this workshop is to give you to have you hear from 3 different people, and then we're going to ask for your participation because the renewal grant that we're doing for this center will have a mentoring component. And we want to make sure that we get input not only from people who've experienced mentoring, professional mentoring, coaching, but also from the communities that we're going to be working with. So this is an organic exercise. So we have 3 panelists, or 3 people who are going to talk with us. Davina Gonzalez, who is a program coordinator. for Reach Out, which is a community organization, and she's the coordinator for AmeriCorps programs and the CHW program, which is community health workers, right? Yes. And of the Inland Health Professions Consortium department. So she's going to be talking about her work and the young people she works with, both from the side of who mentors her, but how she's mentoring them, because these are going to be some of our future students in the healthcare professions. We also have Dr. Mario Sims, who is one of the people that we've recently recruited to UC Riverside. He is a professor in the Department of Social Medicine, Population and Public Health. And he is going to share with us his mentoring trajectory, but also the things that worked and the things that don't work so well in this system that we have. And then Dietrich Galloway, who is a doctoral student in medical anthropology, is going to talk about her experience as a professional coming into academia and how mentoring has helped or not helped her. So once we hear from all three of those folks, then we're going to ask you to talk about your mentoring experiences and to give us some information that we can use as we move forward. So let's start with Dina. Dina, talk to us about mentoring and your mentoring experiences.
So hi, everybody. I talk really loud, so I don't know if you can hear
Use it.
Use it? Okay. Let me clip it on.
It's being recorded. So.
Okay, thank you. So hi, everyone. Can you hear me? Okay. My name is Davina Gonzalez, and as mentioned, I am a program coordinator for a nonprofit in the Inland Empire called Reach Out. We service San Bernardino and Riverside County, and we have a variety of programs. I would be lying if I knew every single program we do. We do so many, but the program, the department that I am a part of is Inland Health Professions Consortium, which is a department that highlights and encourages young students, and any student, not just young students, we encourage them to pursue health careers in the Inland Empire and keep those students in the IE. As you may know, a lot of individuals that live in the IE, they go to school, they venture out, and they leave us. They leave the IE, they go to Orange County, LA, which is amazing, but the IE unfortunately continues to not have as many opportunities as we would, right? So that's the part of the work that the IHPC department does, and I'm in charge of the AmeriCorps Public Health Community Health Worker Training Program. At my time with Reach Out, we have done many cohorts. We have an apprenticeship with individuals that are already doing the work in the community. We also have a certification at the end of our program upon completing a fieldwork experience. And then also, very recently, we completed our first ever monolingual promotores CHW cohort, which one of them is here. Hello. So we are so proud of our students. I'm extremely proud of my promotores, my promotoras that completed the program. And they're from all walks of life. They have, different educational experiences from their homeland and also coming in, or just maybe a stay-at-home mom that wanted to come in and, do the good work in the community. So I'm so thankful to be a part of that journey for them, and I'm honored to be here. So thank you.
So tell me, what has been your own mentoring experience? Who's mentored you?
So I thought about this question long and hard, and there's been many people. My mentorship experience started from a young age. I grew up in Ontario, and I was in recreational and community service spaces. If you're familiar with the city work, they have different community centers and such. I started as a recreational leader, as you would say, bottom of the chain, and I helped with different programs there. Through that experience, I then moved on, to school and meeting other people, other directors, managers, and all of those people have added to my mentorship experience. They've helped add to my confidence. They helped add to my creativity and what I feel that I can do and the work that I do. So that is just to say very briefly where it started and how I got to where I am now.
Okay. If we were putting together a new mentoring program here for our project, what kind of advice would you give us in terms of that?
Thank you. I love that question. I think just being transparent. I think if you have individuals working closely with the students or participants that are wanting to be mentees, be transparent. Talk about the hardships. Talk about how not easy it was to get here. I know for me, being first generation college student, which is the tale of many, and also third generation Mexican American, I didn't grow up with many resources that other peers did. And me even knowing what public health was, I didn't know what it was at first and what those efforts look like. And just talking about being transparent with how you get to somewhere and how you get to be in that mentorship role is important, and being vulnerable. And maybe you're working with a population you don't know much about. Think about foster and homeless students and the hardships they go through. And those students turn into adults, and then you don't know anyone's story from meeting them. So being transparent and being a little vulnerable as well, getting to know them.
Okay, thank you. So let's go to Dr. Sims. You've had a journey. You are now the professor in a new department. So can you talk a bit about your mentorship journey and talk about some of the people that have worked with you? And I'll ask another follow-up question.
Okay. So, yes, it's good to be here on the panel. And so my mentorship experience varied widely and has been, I guess, extended over the last, 40 years almost. A lot of my experiences started by just regular programs I was a part of in school in the South Central Los Angeles area. I grew up in Compton. So I was a part of a lot of like summer programs and I guess college ID type programs. And I always saw people doing what I wanted to do. So just seeing people in those areas, if not, physicians, researchers, engineers, scientists. And so seeing that, made me have a picture of what I could become. So those became some of my mentors in undergraduate at UCLA, and also worked with several minority professors at UCLA on summer programs, research projects, and the like. And I sort of saw the things that they were doing, the kind of temperament they had, the kind of schedule they kept, how they related to students, and, adopted some of the things that they did, but not others. They were very straightforward with me, very directed and guided as far as having a purpose for what I was supposed to accomplish. So that was very helpful. The things that worked was having things in place, having some deliverables in place, having an objective in place, writing it down, revisiting it, being accountable, and the like. So not only being mentor from faculty as a student, but I was fortunate to be in peer mentoring positions. So I was also mentored from from a lateral position, but it was sort of a horizontal mentorship too, where peers of myself, as a student, as whatever, could mentor each other and hold each other accountable. So that was very, very, very important. And then the third phase is you begin to mentor others behind you. So it's a three-phase kind of dynamic, and that was very, very helpful to me as it continues to this day. So does that help?
That helped. How do you use mentoring in your work today?
It's like it's rather than being more or less position driven, I think for me, it's more mission driven as far as developing the pipeline, if I could call it that, for people of color coming behind me. And just students, period, having that as a mission. I worked for the Jackson Heart Study for the last 20 years, and we had a mentorship.
Can you explain what the Jackson Heart Study is?
Sorry, it's the largest cohort study of African Americans, men and women in cardiovascular disease in the world. It's funded by NIH, or the institute specifically is National Institute, National Heart, Lung, and Blood Institute, NHLBI, as well as NIMHD, which principally funds the HDR here, UCR. So, I've been a part of that program or study, which a component of it was mentorship or training. And so we developed a curriculum, and we had objectives made for students who were at the master's level, PhD level, or undergraduate level, or even early career scientist track who wanted to do cardiovascular disease epidemiology. So we had a set of, guidelines where we could outline with them objectives and deliverables. What are you going to get out of this program? And then we also track them, see where they are today. That's always good to know, and how your program may have inspired them, things that you did, or things that you did not do, and you can sort of learn from that, as well as have a strong evaluation component in place. That really, really helps you. You can assess the the work, the program, if it delivered what you originally intended to.
So the idea of evaluation is, and evaluating programs for effectiveness is really important.
Yes, that's very important.
What kind of advice would you give to people who want to start an effective mentoring program or have an effective mentoring program?
I think one of the things is to find out who's doing that type of program and see if there's a model that's built that might fit you. I mean, why reinvent the wheel? So find out what's being done out there, and you may tailor it to your own subpopulation or your institution or the capacity of faculty or mentors that you have available. I think that's very important because it'll give you a good start and a good confidence that you're, sort of on the right track, and that there's some effectiveness built in from a scientific standpoint, experiential standpoint, and you can sort of gauge how the effectiveness in your own program. So I think something like that will be important.
I'll ask you all this question at the end, but so be thinking about it. How would a mentoring program that is focused on ending structural inequalities and justice perhaps differ from traditional mentoring programs? Think about that, okay? Dietrich is in the process of becoming, she is in the pipeline to be a medical anthropologist, but she's had some really interesting experiences. Dietrich, would you share your mentoring experiences, how you've gotten to where you are, and how mentoring has helped you or not?
Hello, everybody. I'm happy to do that. First, I'd like to say that I am a product of community-based education. I was initially a vocational trainee for cosmetology, and that led me to start my own business. And then I went to school back to community school, and I learned data processing. And that landed me a job at Blue Cross of California, and I stayed there as a data processing programmer for the actuarial department at Blue Cross of California, and I was there for, I would say, about 20 years. And after that, I became jobless. So I didn't have a job. So I had to figure out how I was going to utilize the skills and the talents that I had earned, prior to becoming jobless in a new career. And so I went to UCLA and I studied healthcare management and leadership, and I received my certification there. And then I got sick. I was diagnosed with multiple myeloma, and I said, okay, everything comes to a screeching halt. And my health was the priority at that point. I had 2 kids. One was in college. The other had graduated college. And so in an attempt to try and find out more information about how to care for myself in a system that didn't recognize me as an equal partner in my care, I began taking anatomy classes, nutrition classes at my local community college that always served me very well, community education. And before I knew it, I had all the prerequisites for the nursing program. And so I was really excited, but I knew that the nursing program was really difficult to get into. There was only maybe 20 or 30 spots in the community colleges. And I got in. I got in. I was shocked. But what was even more shocking was when I got in, I was the only Black person out of a cohort of 40 students. One. So obviously the mentoring opportunities for me as, first of all, a non-traditional student in the sense that I was much older than my colleagues in the cohort, and as an African-American woman, there were no mentoring opportunities for me. So I just kind of had to draw on, my nature as an African-American mom. And I got into the program, I started clinicals, and the first thing that I became aware of was that when I got into the clinicals, the nurses were not taking care of the patients. I would come in one day and I would see a patient who was comatose, and his Foley sac was full of excrements, and I'd come in the next day and it would still be full of excrements. And I was like, oh my God, this is insane. This was nothing like
television.
It was nothing like what I had learned in school about nursing. It was nothing like I had learned about at UCLA, with, crossing the quality care chasm and, patient-centered care. It was nothing like that. I was incensed. I just couldn't fathom what was going on. And then I come from a line of nurses. My grandmother was a nurse. My mother was a nurse. I can remember my mother telling me, you need to become a nurse because Black folks need to be able to see people who looked like them when they're being cared for in hospitals. That's why I chose nursing. But I needed to go deeper. I couldn't do what I wanted to do as a nurse. And so I enrolled at Cal State Northridge in their public health program, where I discovered that Black people, African American people, dominated just about every category of health disparity that there was. Another eye-opening moment. And what was even more concerning was my classmates didn't bat an eyebrow. They were not shocked. I was like, why am I the only one shocked about this? How could Black people be dying of cancer, be dying of breast cancer, be dying of diabetes, heart disease? Why? Why do we die more than everybody else? So I get my public health degree, and I go deeper. I get into the anthropology department, and there I discovered it was just like the speaker earlier today said. There is this importance to, to continue to perpetuate the status quo. This is very important for society. It's important to recognize the way that things were in this country and to give that some credence and some value, and to kind of sweep under the carpet all the ugly stuff. But in anthropology, I'm learning all about that ugly stuff. And in anthropology, I have some amazing mentors. And they just cut right to the chase. They tell me all the truth. But I did not have a real good mentoring base prior to coming here.
Okay. Thank you. Now, let me ask you all that question I wanted you to think about. What would a mentoring program that speaks to the values of what we want to do in our center look like for you? What are the kind of components do you think should be in that kind of mentoring program? I'll start with you, Davina.
So I think for me, and kind of going off of what Ms. Diedrich said, it sounds like representation. I know that that's a hot topic, right? Everything now is representation. But sometimes we don't get it right. Sometimes out of that representation, we pick the 1%. How about we pick people that maybe don't get these opportunities? I think even right now, like I mentioned earlier, I'm so honored to be here. I didn't go to UCR. I couldn't get into a UC. Can you believe that? And then here I am. I didn't get into a UC. I came from Ontario, the corner of Ontario that was, you cross one street, Rancho, one street, Upland. Nothing was nearby. And if you know that corner, you know what I mean. So having representation, maybe students that maybe don't even come here, maybe look into communities or people from communities that have had to navigate maybe a little bit more circles than other people, and have those people come and share their stories. As I mentioned, transparency is super big. I feel like when I get vulnerable with my students, and not everybody, of course, there's a time and place, but even with my promotores, again, as I mentioned earlier, I'm a third generation Mexican American. I didn't grow up speaking Spanish. In my area, I'll be quite frank, I'm 27. When I was younger, speaking Spanish wasn't cool. So I didn't speak it. And I would try to speak it at home, and I'd be like, no. I mean, now, obviously working, I had to learn, because then people or other mentors would throw them my way, the people, and be like, hey, help them. And here I am with my Spanglish, or as people say, no sabo kids. That's me. I'm like, oh, how can I help you? And I learned that way. So I feel like building those connections with people. I mentioned I was in community and recreation spaces. I've dealt with youth, tiny tots, adults, elderly adults. And no matter what, if they had a question for me, I would never turn anyone away. I'm like, okay, let's figure this out. What do you need help with? How can I get you to where you want to get to? And there's things I didn't even know about. Public health and health careers, I didn't know how to get there. I didn't even know what public health was. I just knew I cared about population and I wanted to help them. And I think we all share that same passion. We probably didn't know what we were doing, but we knew we wanted to help. And so I think for me, a really important component in a program is looking and outsourcing to communities that may not have those chances, and that representation, it matters.
Thank you. What about you, Dr. Sims? What advice would you have for us?
I think it's important to shape the training program around the objectives of the major grant. You have to be consistent in your messaging. If it's one of looking at health disparities, health inequities, health injustice, or whatever, that the whole training and the design of it has to be, shaped around that major objective. That's very important. Mm-hmm. Number two, you have to have mentors available. You can't strain 1 or 2 or 3 faculty. Those who are able to train and mentor students in areas of health disparities. What that means, to have a sensibility to it, understanding and some skill set to move you from A to Z in whatever deliverable is designed for this training to get. If you don't have that in place, you have to have some type of training module, training the students or training the faculty on how to mentor in this area. I think that's very important, especially from a CME standpoint. You know what I mean? I just think that's needed, because a lot of times we may reach outside of immediate areas of like public health, epi, health behavior to try to get people to mentor students in these areas. And then number 3, you have to have the students available. Mm-hmm. You have to have catchment areas, sub-areas, programs, departments that may have these students who are interested in these areas. Because a lot of the times I've worked with students who just wanted to, check a box, but they really didn't have the motivation or the desire to really understand the topic and to move forward in it as a mentee. So I think that's very important. I think those are mine.
Okay. Yeah. I have a handout, and I'm asking Liz to pass them out now. Oh, you already have them? Is that on the left-hand side of the paper are quotes from actual faculty from UCR, and this is part of a small research project that we did in our unit. These are senior underrepresented minority faculty experiences, and we wanted to make it real for all of you, so that this was not just something we pulled off the internet. Although the QR code will take you to a list of readings for you on mentoring or mentorship if you would like to learn more about mentoring for success as we think about it. Okay, so now what we're going to do, I put up these 2 group discussion questions, and we're in a big room, and I know it's hard for us to get together, but if we could make 3 groups, and what I'd like for you to do is to give us feedback on these 2 questions. We're going to have someone in your group taking notes, so you don't have to take notes. What has been your own mentoring experience? How has it helped you? And again, that second question, we're serious about this. What kind of advice would you give to people who want to start an effective mentoring program? And we will be doing that here at Riverside. We're taking all of the information and we're going to incorporate it into our new mentoring program that we're starting at UCR in the HDR.
Welcome back, everyone. Thank you so much for joining us for our last but not least session. I would like to introduce Dr. David Lowe. You have already heard him speak several times today, but we're going to officially introduce our leader. So Dr. David Lowe is a distinguished professor of biomedical science at the University of California, Riverside School of Medicine, where he's also the senior associate dean. He has over 40 years of experience in molecular cellular immunology, including a few years in biotechnology. He was one of the original awardees of the Grand Challenge in Global Health from the Bill and Melinda Gates Foundation with a project on needle-free vaccines, and he is a fellow of the American Association for the Advancement of Science. He is principal investigator and director of the Center for Health Disparities Research, the reason why we are all here. And it's an NIH-funded center supporting training, research on health disparities, and community engagement. His recent research has focused on environmental health disparities in the Salton Sea region, especially their impact on the high incidence of childhood asthma among Mexican immigrant communities. So it's with my honor and pleasure that I introduce to you and bring to you our last speaker on his research, Dr. David Lowe.
Thanks, Michelle. I'm not going to take too long. I wanted to use this talk as a way to illustrate all of the things we've been talking about today, to illustrate how it is an interdisciplinary, collaborative project, how it is so incredibly dependent and benefit from input from our community partners, and it continues to benefit from ongoing conversations with our communities. So let's see here. Okay, I skipped that. That's just the paragraph. So the idea here is that it's truly interdisciplinary because we're not simply saying, are there social determinants of health in Mexican immigrant communities? It's actually a confluence of two different ongoing things that are happening that combine with the kind of health effects that we're seeing. So one is that the socioeconomic conditions affect the Mexican immigrant farm worker communities and where they're really able to afford to live, which would be near the Salton Sea. And that limits both their economic impact as well as their impact in political circles and so on. Meanwhile, a parallel phenomenon is the crisis in the drying Salton Sea. So the chronic drought is causing shrinking of the Salton Sea, and the exposed lake bed is causing more and more dust being produced at the exposed lake bed. Dust by itself is not a healthy thing, but other things that we've been studying have made it so that the dust is relatively toxic, and the people who are forced to live close to the lake are mostly impacted by the dust that they have to breathe. And that's the kind of confluence of two different types of disasters that are affecting these people. Okay, so I wanted to, again, talk about community engagement as an important part of what we're doing, that our principal is that the community engagement is not simply a question of dissemination, but having a trusted relationship with communities so we can get information with them and include them as full partners in the research projects. So we have community advisory boards, we have ongoing conversations with families who live in the region, and they include questions like, why do my kids have these symptoms? What are the things that are causing this? Do I have to worry about lithium extraction in the region? As well as questions like, how do I connect with our assembly member or congressman and tell them what's going on so that they can actually do something about it? From the research point of view, the families also tell us things like, well, this neighborhood is really worse off. The kids have worse symptoms here this time of year. So it actually informs our research in terms of where we do our sample collections and what kinds of things we're looking for in the research project. So this whole issue of engagement is not just dissemination, but actually a back and forth communication with the communities that we are basically partnering with. And as I was explaining a little earlier to somebody, that the more information we gather with partnership with the communities means that we have more information that communities can go to agencies, legislators, and things like that. It's like we now have the hard data saying this is the problem and you need to do something about it. So it's really a part of also empowering communities. A little side note is a part of the engagement is finding creative ways to interact. And so I don't know if you noticed that we had piles of comic books out there in English and Spanish. And it's what we did. We hired a couple of comic book artists to create comics to come up with creative ways to communicate the research and what are the issues there in terms of the saltancy, the dust, and how they impact health. So it's just a starting point to try and communicate so they have regular ways of getting informed in the community, have topics for discussion, and also a starting point for further research. And comics, I think, is a really creative way. It doesn't necessarily have to be targeted just to kids. We can address these questions and explain them for the families as well as for the kids. Okay, so the research part of this is I'm not going to burden you with technical details, but so I'm always surprised to discover that many people who've lived in Riverside all their lives have never heard of the Salton Sea. And it is California's largest lake. It is in inland Southern California, and it was created when the irrigation canal broke and stayed open for 18 months and just filled in the salt basin. And for years, it was a recreation site, all this real estate development and so on. But the only input now is agriculture runoff, which includes things like fertilizers, pesticides, things like that. And as the lake dries, it's become more and more salty. It's about twice as salty as the Pacific Ocean, and it's producing incredibly high levels of dust at the drying lake bed. And people who live there, predominantly Mexican immigrant farm workers, are breathing this dust and not knowing what's in it and what the health effects may be. So we've been doing studies on the material that is, Yolanda, say happy birthday. We are collecting samples from that region and looking at this question of what real health effects there are from the dust there. So one of the things that got us involved in studying this is that we heard from the families that childhood asthma is incredibly high. And depending on where you look, there are estimates where the childhood asthma rates could be as high as 30%. Now, the problem, of course, is that many of them are undocumented, don't have health insurance, and so they often don't see doctors. They often go to Mexico, see families, and pick up, inexpensive inhalers. So they never get tested. They never get a workup or an actual diagnosis, but the symptoms suggest we have a very high incidence of childhood asthma. And so the question is, what is going on? And is this linked to something produced at the Salton Sea? And so the studies that we've been doing, looks like my lab is all sitting here in the middle of the room. Yeah. Is that the dust that's produced at the Salton Sea is very specifically toxic and producing the inflammatory responses that we think is really directly responsible for the high incidence of asthma we're seeing. So not all dust is dust, and there's something particularly toxic about the dust we're seeing at the Salton Sea. And you'll see a bunch of comic illustrations from in these slides, and you'll see really talented artists. Now, as I said, the dust levels near the Salton Sea are higher than they are in other areas further from the Salton Sea. And that exposed lake bed is really particularly productive in terms of dust levels. And so we're trying to figure out the question of how that is doing it. So you can see all those little animals out there in the air. So what we want to know is whether or not all these little nasty bits in the air are actually going into the lungs and causing inflammatory responses. And so this is show you a little bit of the kinds of things we're doing. Now, there's probably two people in this room who get this slide, so I won't waste your time on it. And the idea is that there's inflammation in lungs, And we often think of asthma as associated with allergic diseases, but not all inflammation in the lung is caused by allergy. And that's one of the points I wanted to make from this slide. So this is a picture of the chambers that we have in the lab where we actually take mice and we expose them to dust material that we collect from various sites around the Salton Sea, and then we look and see how the lungs respond to that dust that we've exposed them to. And what we find is that depending on the material we expose them to, and we can do these exposures over long periods of time to try to mimic the exposure of the people who actually live by the Salton Sea, and then we look at the effects on inflammation, gene expression, things like that. And as I mentioned, because of our discussions with the families and communities in the area, we've collected dust and other materials from around the Salton Sea at various sites all around the Salton Sea, as well as things we've collected further away from the Salton Sea. And then we've done the exposure studies, and we found that if you take dust that was collected like closer to Palm Desert and so on, the mice don't see any kind of response, no kind of reaction. However, if we take dust collected from very close to the Salton Sea, that's when we see this kind of inflammatory response. And the surprise for us is it did not look like an allergic response as might be expected if you're talking about asthma, but instead it looked like a different types of inflammation instead. And so hence this slide where we think that the inflammatory response we're seeing is more typical of what would happen if you inhaled things like dust containing all kinds of bacterial or fungal or other kind of microbial components where you get a different type of inflammation. And the thought is that what's happening is that as the Salton Sea has all this runoff from fertilizer and stuff like that, the bacteria and algae and fungi that overgrow in the Salton Sea, and as they overgrow and die, that material gets picked up at the shoreline and the exposed lake bed and pulled up into the dust, and that's what people are breathing. So among the many types of things that we are studying with our team of collaborators is what are those bacteria? What is that microbial ecosystem like? And what is the changing environment because of the salty water, because of the fertilizer and pesticide runoff? What are all of those things doing? And so the thing is that it's only getting worse. As chronic drought is making the Colorado River dry up, as some of the water is being sold off to places like San Diego instead of using for agriculture and being drained into the Salton Sea is now drying up even faster. And so if we look at it in the context of things like the global question of things like climate change, it's these issues of drying lakes, changing ecologies, and the dust that's produced as a product of that are going to be emerging health issues, not just at the Salton Sea, but in other parts of the country as well. You may have seen news reports about how this is having a similar impact in Salt Lake City in Utah, where the drying Salt Lake is having a similar effect on health in that region. So, as I said, this is not going to take too long, but again, I wanted to point out how we have relied on our partnership with communities to lead us into a very challenging research question that has direct impact in understanding the health impacts and things that could actually lead to change, whether it's government policy change affecting the status of the Salton Sea, changes in looking at healthcare is effectively going to be used in these communities. So this is the last slide, just showing all of our partners. We have not just done this with the studies from the Health Disparities Center, but also from funding from CARB, who of course is hosting this lovely meeting. We had a number of community events, and the same brilliant team that produced this event also helped produce some of these community forum events in the Coachella Valley and Imperial Valley. Our comic book artists, our environmental microbiology people, our engineers and climate modeling people. And you can see also we have some funding from oh, I'm sorry. Oh, sorry. I thought that one was prettier. But in any case, a whole lot of people on the team, as well as all of our partners in the community, Alianza, Comité, the HARC, who's helping us with some survey studies, other community partners. We've been having a number of conversations with 29 Palms. We have some funding from the congressional district, and so on. So a lot of different ways in which the work that we're doing has now been able to draw in interest and support from other parts of that community, where we hope not only will we understand the problem better, but also find some ways to actually approach and address these issues with the community. So anyway, so that's my last slide, sorry. And so I hope I was able to convey that the importance not just of the interdisciplinary part and the broadly collaborative part of this project, but also the importance of the community engagement and how they really drove this project to really focus on the important issues in this community. So thanks for your attention. Thank you all for coming today. See you all back here tomorrow. This has been a really great meeting so far. So I'm really glad to have you all. Great discussion. So thank you. And I guess I could take a question or so. So one of the challenges we have as researchers is, you know, if we want to advocate for better solutions for health, right? Now, the challenge, and one of the most frustrating things I can tell you from having worked in this area for several years now, is that nobody actually has an answer to the question, like, how are you going to fix it? So while it would be lovely to be able to advocate for solutions, nobody's come up with one. You know, people say, oh, pour more water in the Salton Sea, or something like that. Well, that's probably not the answer. But if we had more attention, if we had more commitment from governments or agencies, then they may actually get together and say, well, let's identify a reasonable and, you know, doable solution, if only to protect the health of the communities. And I know we had talked about this in some of the earlier talks about, you know, you can do things because maybe it's an economically, you know, expedient thing, like, say, the lithium extraction. But I mean, the whole moral aspect of protecting the health of 500,000 residents seems to be important, you know? Thank you. That's good. So this is another part of that. If we can really say that, you know, these bacteria are the cause of this, it's not an easy answer, because we can't just say, you know, like, toss antibiotics in there or anything like that. That's not going to do it, right? Or just everybody wear face masks. I mean, we've had anecdotal evidence that because of the pandemic, more kids were wearing masks, and so they had fewer symptoms. That is clearly not a solution either. So we've, you know, sat around thinking about crazy ideas about changing the microbial environment and things like that. But, you know, that's how science fiction horror movies are made, right? You know, here's my solution, and this monster comes out of the Salton Sea. I don't have a good answer to that. And again, goes to the other question. It's like dumping water in the Salton Sea is not necessarily the answer either. And I can tell you, it's a very frustrating thing. As a scientist, we are identifying as much as we can about what is actually going on and what harm it's doing to people. It's another thing entirely to say, well, how do we fix that? And I wish I had better answers. So there are all these YouTube videos out there saying, oh, well, you know, they secretly lost an atomic bomb in the Salton Sea and things like that. And our lab did we did a movie thing. There is actually a science fiction movie about how this monster. Yes, the Navy used to train out there, and And you know, the thing is, these ecosystems, you know, talk about man having an impact. The reason those beaches are pink is because the Navy boats brought into Salton Sea brought barnacles, and they took over the ecosystem. So you don't even have a normal ecology in the Salton Sea, and it's just because the Navy opened that training base there. So there's a lot of stuff we don't know, and then they closed it, and we don't know anything about that either. So I am totally sympathetic. There's so much we don't know. Yes, I totally agree. Now, when you talk to the indigenous, the Indian tribes, they will remind me that the Salton Sea has come and go many times in the last many thousands of years. So they have a different perspective on it. And it's interesting because, well, you know, it could dry up, something could happen, it could flood from, you know, Baja or something like that. So it depends, you know, we have this perspective where, you know, there are movies from the 60s and 70s showing this as a wonderful resort area. Or, so again, our perspective of time is what's affecting us now. It's like there are people living there now. There's people working and suffering, and kids with chronic asthma who there's no cure. And there are people who are waiting for things like lung transplants because of the severity of this. Now, I don't think it's because of the Navy. I think it's because of the other stupid stuff we've done. And so that is only one of a long list of issues we've got to deal with. So I'm not diminishing that. It's just that we have, this is one of many things we're just not doing anything about. It's incredibly frustrating. So the Indian tribes prefer to say, don't call it an accidental man-made lake, because they want to take it out of that context as like, oh, well, you know, this happened, we can fix it because man can do anything. And so again, it's like, what perspective, how do we view this? And you know, but the problem is, you know, your kid still has asthma. Well, government, so legislators are not scientists, mostly. And so, for example, the Inflation Reduction Act set aside $250 million for Salton Sea. They didn't say what. They just said Salton Sea. So they're just throwing $250 million. They gave it to the California Natural Resources Agency. They don't know what to do with it. So even if you say to let the governor or the congressman, things like that, we need stuff, right? They'll just throw money and think they've done something, which is not the same thing, right? Well, I go back to my statement that legislators are not scientists and certainly not physicians, so I would believe they're far less likely to think carefully about a solution. So I think it's up to the community because they live with it, right? We can help, right? We can together have these discussions and say, you know, what sounds reasonable? What can we do? And then go to the government and say, you know, let's try this. Okay. Any other? Again, thank you so much for coming. This has been a wonderful day. See you all tomorrow. Well, yeah, see you tomorrow, and hopefully we'll have more conversations. And thank you again.